So the drugs that are currently approved for Alzheimer's disease there are four of them basically, and three of them are in one class, and then the fourth one is a little bit different. So the three that are in one class are, I'm going to use the brand names because I think these are the ones people are most familiar with, but it's Aricept, Exelon, and Reminil. And those three drugs all work by boosting up levels of the brain chemical called acetylcholine, which we know to be low in the brains of patients with Alzheimer's disease. And because they all work the same way, they all have the same side effects. And as a result, people are just on one drug or the other among those three. People pick one of these drugs. There's not a lot of good evidence that one is any better than the other in terms of efficacy. So we usually think of these as more or less interchangeable. Now, these drugs have been studied according to the gold standard for drug development, which is double-blind, placebo-controlled trials, meaning studies in which patients take drugs, take a study drug, and neither the patient nor the treating physician knows whether it's an active drug or not. And then all of the assessments are made in this blinded state to try to remove any wishful thinking from assessment of whether the drugs work. And in those types of studies, these drugs have shown treatment effects. They've shown modest benefits. At the end of 6 months, sometimes at the end of 12 months, when the patients on treatment are compared to the patients on placebo, the patients on treatment fare better than the patients on placebo. And that's something that's pretty consistent across the drugs and across trials, and I don't think people argue that point very much. And it's that type of data that has led the FDA to approve these drugs. What people argue about quite a bit is whether the magnitude of the effect is really worth the cost of the drug. So the magnitude of the effect is very small in general when you compare these populations. So it's generally 3 to 4 points on a 70-point scale. And whether that is a clinically valuable effect or not, I think is really not a matter of science. It's really it's a value judgment, whether these small effects are worth it or not. A minority of people who are treated with these drugs, meaning 10%, maybe up to 20%, have a more visible effect. They really seem to be obviously benefiting from the treatment. After they start the drug, the family can see an improvement. Some of the test scores can grossly improve. But it's not a black and white effect in most patients. Now the fourth drug is called, the brand name is Namenda. Namenda works by a different mechanism of action. It blocks a receptor for a different brain chemical, so it's a completely different chemistry from each of the first three drugs. And even so, the comments that I made about general efficacy hold for Namenda just as they do for those other three drugs. That is that Namenda has passed the bar set by the FDA for drug approval, but the magnitude of the effect is small. That's not to say that there aren't a few people out there who are robust responders, but the overall magnitude is relatively small. So when you hear people talking about these drugs, you hear sort of two ends of the spectrum of opinion. That is, the people who are selling the drugs are making the point that these are really valuable drugs for having dramatic side effects, and everybody with a memory problem ought to be on them. And people who are trying to control costs are at the other end of the spectrum, saying these drugs are just, they're not so effective that they're worth the retail cost of them. And my feeling, and the feeling of a lot of clinicians, I think, is somewhere in between. That is, that we think these drugs are worth trying for the sake of at least offering them to the people who are robust responders. We don't know who those people are in advance. And that there may be some effect in making a sick brain a little bit better that may be clinically valuable, just, regardless of what the magnitude of the effect is. I guess just a couple of other points about the drugs that are available. Strictly speaking, Namenda is only approved for people with moderate to severe Alzheimer's disease. So these are people a little further along in their level of impairment. Aricept is approved for well, I should say, all Aricept, Remenil, and Exelon are all approved for mild to moderate Alzheimer's disease. And through a fluke of the drug approval process, Aricept is also approved for moderate to severe Alzheimer's disease. But really, probably any of the cholinesterase inhibitors, any of those first three drugs can probably be justified through the course of the disease.